Alrighty, let's have ourselves a webinar. Boom, boom, boom. Where did that go? Stop share. Welcome to the Tidepool for Telemedicine webinar. My name is Christopher Snyder. I'm Community Manager at Tidepool. Again, I will promise to speak as slowly as possible, despite how exciting these topics are for me to share with all of you and to engage with the Tidepool community as we engage in this telemedicine present that we're now living in. Joining me this week is Mark Harmel. Hi, Mark. I've changed the view so now everybody can see you. That was a little selfish of me. Sorry about that. So yeah, Mark Harmel is he's a not a certified diabetes educator, is a certified diabetes care and education specialist. I'm going to get that right. Operating out of USC. Yeah, that's a whole other thing. But yeah, Mark is here actually to help me and to help all of you get a better understanding of the technical logistics of telemedicine. And part of the journey today is going to be Mark sharing his experience, what he's learned, and the sort of process that he works with Dr. Ian Peters out of USC. And throughout the entire webinar, as always, in case you are new to these webinars, there's a Q&A button down at the bottom. You can click on that and ask questions as you go. And then Mark and I will be addressing those questions during the webinar as necessary. Before I hand it over to Mark, I do want to handle a couple of quick logistics and paperwork here. Bring the screen share back. So again, for today's agenda, Mark will be talking about the technical logistics of telemedicine. There will be time for Q&A in the middle and at the end of our webinar as we have time and as the questions do come in. From here, I just want to remind everybody that tidepool.org/telemedicine is the URL that you should be bookmarking. And this is going to be the hub for all the telemedicine content that we have for you as clinicians and also for you as patients, because I know that you are out there watching these webinars as well. In particular for clinicians that are watching this webinar, either live or the archive, on the clinician side of our telemedicine content, we've updated some of the resources that we have available to for you to share with your patients, including some social media assets that you can share on your personal or clinic branded pages on LinkedIn, Facebook, or Twitter. Again, these are not requirements, but they are suggestions in case you would like to use something that we've created to give you an idea of how to share that you're using Tidepool to engage with your telemedicine efforts. As a reminder, we've already done a bunch of webinars. Those archives are publicly available on tidepool.org/webinars. You can go there and see everything that we've done previously, and also you can register for webinars that we have upcoming as well. When in doubt, again, support@tidepool.org is the email address that I'd like you to be contacting for any questions relating to getting started with Tidepool, to using Tidepool. If your patients have problems, send them to support@tidepool.org and we will be ready to help you out. Upcoming next week, we've got Amy Jose, based out of the San Francisco Bay Area. She works at Steady Health. She'll be talking about the emotional logistics of telemedicine. We've got a registration link that will be upcoming for that webinar in case you are curious about that. And outside of the telemedicine focused stuff, we're starting to branch out with our webinar sort of content strategy. I'm not sure if that's a really good phrase to use, but I've said it live, so there we go. Starting with one of our product designers, Paul Forgione. He gave a presentation a couple of months ago to the Tidepool team talking about designing for accessibility with color, and I've asked him to give a version of that presentation to the broader Tidepool community. So we're going to be doing that next Tuesday. I'm actually very excited for that one. It'll give a really interesting look into how we take a thoughtful approach to design when it comes to color contrast and just using color in a more accessible way for us. That said, I'm done talking for a little bit. Mark, just make sure I can figure out how to actually get out of this, this screen share. Oh no, we have to scroll through here and stop the screen share. There we go. Now I've stopped the screen share. Mark, you're it. Take it away.
All right. Now, are you seeing things now?
I'm seeing you currently.
You're seeing me?
And the lovely office backdrop you've got there.
Thank you very much. Do we get screen share or to make me the host to share my screen?
You should be able to share your screen as is, I believe. Let me try it. Yeah, all panelists, you should be able to give it a go.
All right. So, are we seeing things now?
Not yet.
You're just seeing me.
Yeah. At some point, you're going to have to narrate what you have on that shelf behind you, though, if the screen share doesn't work.
Can you make me the host?
I cannot. Make co-host. Let's try that again. How
I'm
about
co-host.
now? I can upgrade you to co-host.
Oh, share screen. Okay. Look at this.
There we go.
Now we tried to pull ourselves off as techies to talk about all of this, and you see how it works in real life, and so this is the way it works. So what do we get for our poll? Do we have sort of a general sense of where we're at? Do we have a room full of experts who know more than I do? Or
yeah, so of the responses, we've got 71% have said they're just getting started and looking for best practices. 29% of responses, about 11 or 12, have said that they're well underway and they have a good process in place. So I think there's a lot of good content you're going to be able to share with everybody.
So a third of the people can help us all out on this, and the rest of us are all learning together. Well, welcome. Thanks for showing up today. And so we have a mix here, and so probably most of you all about patient medicine. And our practice is led by Dr. Ann Peters. We started switching over to holding telemedicine visits in mid-March. And initially, we were just like holding the meetings on computers in the clinic, and sometimes people would be coming into the office, and we would see some people live and in person. The rest of them would be telemedicine visits. So we were still in the mothership of the office. Now we also had to decide, do we use the university design system for doing telemedicine or using Zoom? And it turns out that I think the university system just got overloaded, and Zoom started working out really well. And it's a HIPAA compliant version of Zoom, so I hope it's better in its privacy than some of the other ones that are out there that we're hearing about. But it's turned out to be a preferred platform for holding these meetings now. Now, as sort of reference, I wrote sort of more patient-oriented article on this, and I think Suzanne is posting the link somewhere in the chat box for this. But one version is running on our clinic site, and it's to help prepare our patients on how to upload, why are we moving over to doing telemedicine, and where do you find resources to start sharing your data with us. So there's a version of it that's on our clinic website, and then it was originally ran on Diatribe as well. And so there's a lot of links to some of the sites I'm talking about. So instead of like stopping and saying, what's the link to that? A lot of the answers are going to be here. And I think we're probably find a way to get you some of these links as well. Now, officially, my job is serving as a clinical research coordinator. I'm normally meeting with research participants in clinical trials, and when possible, I'm back in the clinic, and I'm serving sort of as this on-call diabetes educator. Now, fortunately, we had just finished a trial, and we were transitioning over to starting up on a new one when all the in-person research visits were stopped. And then I switched over to doing sort of Zoom, meeting tech support. And I was originally doing the scheduling, preparing the patients for their telemedicine visits. And it was this huge crush of switching over all of a sudden. Now, and then we switched to everyone working from home. And unfortunately, our normal office scheduler took over the role of sending out the Zoom invitations and then being in the host in the room, because there's like one Zoom window that's open. And of course, when you see your doctor, there's always, you always have to wait in the exam room. And if there is a way to have sort of a waiting room in Zoom, we haven't figured it out yet. So you have to like finish the previous meeting before you can start the next one. So I was, calling somebody up on the phone saying, Dr. Peters is still, talking with somebody, and, I'll let you know when it's time to ready to come on in. So there's all that juggling to do. And so it's like every 20 minutes, somebody is new, and seems like she's always running behind. And so fortunately, I don't have to do that part anymore. And as many of you know, that's working in the clinic and trying to get all the devices downloaded before the visits, it's just, you know, it's a mess. And, you know, it's always really hard to do. You have to find the cable and the workflow and generating, printing the reports, and it's just sort of this high wire act, and it's hard to make it work. Now, these were done by our medical assistants, and they were grabbing the devices, and they were, you know, the meters and the CGMs and everything. And then they were also doing the vital signs and then doing the A1C test. And now we have to try to do that big job and try to have the patients do it and do it from their house. So that's my job now. And it starts out by going into the medical record and taking a look at the history of the patient and what kind of diabetes do they have? What kind of devices do they have? At least what kind of devices did they have at their last visit? Because, you know, sometimes there's notes thinking about getting a Dexcom. Did they actually get a Dexcom? Thinking about moving to a tandem pump. Did they actually do that? Sometimes it's hard to know. And so you call them up and say, well, what are you doing? And what do you have to share with me? Now, fortunately, people are sort of stuck at home, and it's easier for us to get them on the phone and contact them. But I use all sorts of methods. I'm calling them, I'm sending them email, and I'm texting them. And it's usually the younger people that I'm texting because they don't respond to emails like somebody my age does. And so I use all methods to like reach out to them and say, hey, you know, we need some data from you. Now, most of our patients, you know, have type 1 diabetes. And it takes a lot of data collection to get them. And there's lots of pumps, there's lots of CGMs, and Tidepool is great for that, especially for multiple devices. You know, especially early on, we had a lot of people on Medtronic pumps or Omnipods and Dexcoms. And before, you had to print out all these separate reports and hope that they all lined up, and they really didn't. And Tidepool was really great for that. And but there's sometimes that it just doesn't work. And so we'll talk about those exceptions as well. Now, a lot of our people are jumping into the loop system. They're willing to go into this brave new world of the open source software of a closed loop system. And so, you know, it works well, and when it's all set up properly and it flows into the Apple Health and to the Tidepool app, it works great. But often somehow it gets stuck, and you have to sort of go into the Tidepool app and manually sync the health data. And for those of you know that Apple has this sort of app called the Health app, and there's ways to share data from different devices into the Health app, and then Tidepool has a way of pulling that data from Apple Health into the Tidepool app and then streaming it up to their website. And so sometimes it gets broke, and so you have to do that. You can do that manually. And, you know, these patients, our loopers, are pretty tech savvy, so it's easy to walk them through doing that. But Tidepool doesn't also get the settings on the loop. So we don't know the basal rates. We don't need to know the carb ratios or the correction ratios. So they're sending screenshots. And so I'm having to track down screenshots for all this and then organizing it and putting them together. Now, patients using Dexcoms and Omnipods, it works really well, but people don't have that cable. And that cable, you know, if they did get it with their old PDM, it's hiding someplace in a box or the bottom of a drawer or something. And you know, I say, you know, Best Buy is still open, run to Best Buy, go out and get one, but they don't always do that. So I have them sort of like, you know, copy it off their device and then send it to me by email so that at least we have the settings on the pump in case, you know, the data suggests that maybe there's, you know, needs to be a change in the basal rate or the correction factor or whatnot. So anyway, we can get something to Dr. Peters as she's talking with them. And unfortunately, you know, she's gotten good at not having all the information when patients come in. So she sort of rolls with that. Now, lots of our Type 1s are on multiple daily injections and are using a Dexcom. So the easiest thing to do is to ask them to do a sharing code in Clarity. So we're collecting this code. Often the code back in the clinic, we had them generate a 1-year code. And so that if they came in every 3 months, we didn't have to ask them for the code every single time. And we could just look it up and we'd have the report available in advance. So that's my first step. Is that code available? And if not, I ask them for that 1-year code and send it to me or read them off. And of course, these are weird letters, and you have to, is that an S or an F? And so is that a, B as in boy, or, is it C as in cat? And whenever it comes to K, I always want to say K as in cat, but, people come up with Kyle and Kalamazoo, and they come up with actual answers for that. And I always get stuck with cat. Then we have, lots of our type 2s are starting to use Libres. Either use them all the time or they use them occasionally. And there's a way to link up the Libre app up to the LibreView website. And once you do that, the data flows in pretty easily. And you can either do that by sending them an invitation, or there's ways to get your practice ID, and the patient can put that into their app, and that links the app up to the practice. So it's a lot of work to do it, but once it's up and running and flowing, it just sort of goes in. And so I'll take a look and see if I see they're using a Libre, I'll look and see if they're in LibreView, if their data is flowing in, and if not, I do the invitations. Now, the absolute easiest thing to do is the InPen. Now, the InPen is this great connected Bluetooth pen, and there's ways to generate a report in the app. And you just sort of simply pull down on it, or there's like a refresh button on there. And then it generates the report, and then you can connect your Dexcom data to the app. And then all you have to do is email a PDF. And it's the easiest way in the world and to do this. And I don't know why can't be that easy for everyone else, just to set up your app so that it becomes easy to email your report. But seemingly, I think all these companies want to collect the data and have the data and track it and track their patients. But the InPen is great because it's so easy to do that. So meters are, it's so hard. There's so many different connections. There's so many different cables and so many different brands, and it's always been a mess, and everyone has their own little software, and patients, being able to have the right cable is pretty tough. A lot of them have those phone jack cables that nobody has, and sometimes there's a mini USB cable that's pretty common that some of these people can use. So, often if somebody's just doing their basal numbers, testing once a day, I just say, you go to the meter, write down the numbers, and talk about them with Dr. Peters. And so that's pretty simple. But we had a patient the other day who is still using a meter, type 1, using a meter, testing between 5 and 10 times a day, using one of these new Bare Contour Next 1 meters. And we just, went through multiple variations. I tried to do Tidepool, and and as I was dealing with the mother, and the mother, had this MacBook Air that didn't have any storage on it, and so didn't have enough storage to download Tidepool. And then I went, well, we used to use this old Glucose Fax Deluxe software, and that's really small. It's this old-timey software that looks ancient. And so she tried that, but the meter was too new for the old Glucose Fax software. And then it turns out that this meter has a Bluetooth connection. And so it's, downloaded in the app. And so dealing with this, you either have to know all these sort of ins and outs and, have to make a lot of these mistakes already, or you sort of learn on the fly and you learn together. So we're dealing with this together, or, hopefully we sort of have been through the process before and know the mistakes that we've made using these bits of software. It's like I had somebody who's, using a 670G and CareLink, and he couldn't figure out how to do his pump. And it turns out that his account still had the old Paradigm pump connected to the software. And looking at the sort of the helper video, I noticed that there's a 600 series pump, and then there's the Paradigm pump. And I said, did you need to add the pump? Because there weren't enough serial numbers available to enter into the website. So I had made that mistake before. And so if we made that mistake before, then we know how to help our patients as well. So, like the 670G pump, the CareLink website has certain features that's available that like Tidepool doesn't have yet. And there's ways, once the person uploads to CareLink Personal, which thankfully doesn't use JavaScript anymore, there's ways to link it to sort of the new improved clinic account. And lots of our patients are moving over to the Katika, the Tandem site. Excuse me a second. So they're switching over to the Tandem with the Control IQ. And right now, the Tandem site does the best job at presenting that data. You can see when somebody goes into sleep mode, where they go into exercise mode, and when the system gives a little automated basal. And you can bring this data into Tidepool, but it doesn't show all those different features just yet. Now, unfortunately, if you have a new Mac running the Catalina software, it doesn't work. And so you can't upload your pump if you have the Catalina software.
Say, Mark, I want to interject real quick here.
Yes.
I actually think that Tandem, this is not a Tandem presentation, but I think they actually have updated their uploader software to support Catalina in the past couple of days.
Yeah. Breaking news. Thank you.
Breaking news. Yes. In terms of that, based on the reports I've seen from the patient community, at least, that actually has come through.
Oh, thank you. Thanks for that. So it's no longer barrier. So we don't have to ask them for an old computer in the house. And then there's this connection. You need their email and password to connect them to the clinic account. Then you can download from that. Now, a great place for resources, if you're using Tidepool, there's a support page, and you can plug in to a search box that you're looking to connect Dexcom data. And there's two ways of doing it. You can use it to go through the Tidepool app, or you can connect directly through the Dexcom account. And so it's a great way to sort of, if you want to use Tidepool, how can they use this device? And there's little instructions for each one, because each one is a little bit different. So now we've moved from this, clinical high-wire act to remote high-wire act. Are we really making progress? So maybe this is a good time to sort of take a little bit pause and then see if we have any questions about sort of some of this sort of techie stuff that we've been dealing with.
Yeah, I got a couple of questions that have come in from the audience. Again, thanks everybody for using that Q&A button at the bottom of your screen. The first one comes in from John. They was asking about any difficulties getting your patients acclimated to Zoom as your video call service. It sounds like you serve such a wide patient population in terms of age range and familiarity with technology. Have there been any difficulties in getting all of your patients sort of comfortable with using Zoom as that software of choice?
I'm going to go into the platform in a second. So it's an advanced question that I'm going to talk about in a second. But it's also going to be, we also confuse people, because our system has this official university thing where we want people to sign a consent form on the university system to do a telemedicine visit. So they're still getting this university sent system. And then their tech support people are saying, now download this app in order to use the system. It's like, no, you don't have to use that app. So we're still in mass confusion at that. And, once we steer them to using the Zoom link, it is fairly easy to do that. And not everyone can do that. And not everyone has a computer. And we have some alternatives I'll talk about in a second.
Yeah. One other question, this one came in from Sally. Thank you, Sally. She's asking sort of about the general ratio, if you can estimate how often you need to spend time troubleshooting any sort of technical issue with your patients. I mean, obviously, because all of this is moving towards telemedicine, there's going to be this high technical requirement one way or another. Every patient population is obviously unique, but how often, or if you saw 100 patients in a week, how many of them do you feel on average would you be having to do some additional troubleshooting or some additional follow-up to make sure that they are fully prepared for their upcoming appointment?
About maybe 25 to 30% of people have like that 1-year Dexcom code, or they're connected to LibreView already. And then, the rest of them, I'm reaching out and saying, what are you using? And so I'm reaching out to a lot. And initially I was also reaching out saying that it's not going to be an inpatient visit, it's going to be a telemedicine visit. So I was doing that and the technical support thing. And right now Rebecca is doing the visit part of it and being the host in the Zoom room. And I'm just sort of doing the reaching out to people. And ideally over time, people are going to get better at uploading things, and the code's going to be ready, and it's all going to be set up and ready to go because we have sort of a stable population. But, our patient population is like 1,000, and it's going to take a while for them to get up and running. And then, of course, they forget, they learn how to do it, and then 3 months later on, they have to do it again, and they're going to need refreshers. So it's going to take a while.
Yeah. So I got 2 more questions and we can get back to your presentation. One is from Deborah. Do you have any knowledge of whether or not there are VAs using Tidepool? I can take this one. Officially, not that I'm aware of in terms of VAs that have signed a business associate agreement and fully onboarded into using Tidepool. We've had plenty of inquiries, and it's exciting to hear about the opportunities there, but nothing formal just yet. But we are working on something which is called a FedRAMP status, which would actually provide sort of clearance for Tidepool software to be used at various VAs. So as we have more to share about that, that'll be something I think we'll probably be making a little more public and promoting whenever that process is complete. As you can imagine, it is rightfully so a very thorough process there. One more question from James. James is talking about using the Zoom service. So I'm going to read this as it is. Is Zoom secure with UK clinicians? He's being told that Zoom is not necessarily a secure connection for patient communications. You mentioned, Mark, that you're using a HIPAA compliant version of Zoom. Is that something you plan to get into in the next couple of slides? And you've got some Zoom stuff to talk about, but in terms of the HIPAA compliant side of things.
I'm at the phase of, we have in order to get on the Zoom version license that we have, we have to use the same sign-in that we use to get into the electronic medical record.
Got it.
And it is a HIPAA version of Zoom, and I'm hoping and trusting that it is more secure than the general version that's out there that we're hearing problems about.
So, and I guess to be a little more precise and respectful, James is asking about UK health regulations. So I can't, obviously, I'm here in Atlanta, Georgia, United States. I can't speak to specific UK regulations. So I would advise you to talk either with your clinician or IT staff, and if necessary, talk to Zoom support and see where they are about proper compliance with whatever regulations and privacy practices that need to be adhered to within the UK's borders. That'd be my best recommendation for that. All right, I'm gonna let the rest of the questions roll in. Mark, if you want to take it away for another round of slides, and we will hop in as we need to with other questions as they come in.
Right, and we're going into sort of, so holding the visits, and it goes back to the first question, what are you using? Is Zoom always going to be working for patients? And the answer is no, that not everyone has a computer, and not everyone is, computer savvy. And but we are finding that iPads working pretty well, and so we have a lot of people who have iPads, and then we're finding that FaceTime is working well also. And then in a pinch, we just sort of go back to using a telephone call. And so it's just sort of talking on the phone. And fortunately, a lot of our patients have long-standing relationships with Dr. Peters, and many of them go back, 10, 20, 30 years. And it's not, unusual for somebody to come in every 3 months. So they have a good relationship with each other. She does lots of support through email and text messages already. And so, just picking up the phone and holding the visit, seems to be working as well. But it's a mixed bag. And, I'm at what I call the technology cusp. Now I'm still dealing with technology a lot, and I'm 66, so I consider myself at the dividing line. That if somebody is older than me, then they may be challenged about dealing with technology, whether that means doing the Zoom call or doing upload. And then younger seems to be, most of them seem to be fine. And, when we get into our 20, 30-year-olds, they're really good. But, sometimes we're asking, do you have a family member that can help you out? Or is there somebody else can help you? Can we make this work? How are we going to do this? So it is an issue. And it is an issue, especially with our older type 2s, but fortunately, often they're just sort of testing their blood sugars. They're doing fasting blood sugars once a day, and they can just sort of like read off the numbers to us. Now, what's interesting about collecting all this data, that I'm sort of flipping the order of the visit. Normally, when I was in the clinic, Dr. Peters would meet with the patient first, and then she would think that, we'll teach you more about this. This person, let's talk about the pump options, and, let's talk about closed loop pump options. So I get called in to sort of bring out the show and tell of the various pumps and pods. And we had demo pods and say, slap this on you and wear it for a couple of days. Can you live with it? Show them what a CGM is, show them the CGM option. So I would be meeting with them afterwards, and I'd be guided by Dr. Peters what to talk about. But now I'm seeing the data first. And so I'm seeing that somebody, has a tandem pump, but they're still using basal IQ. Do they know that control IQ works? And so I'm talking about these new things. And so, I'm seeing things that are somewhat weird. And I'm seeing somebody who moved to a G6 who's doing multiple calibrations a day. And it's probably just sort of confusing the system. And down below, you see somebody who is on the loop system and is just letting it sort of handle everything, every now and then giving a bolus for food, not putting in carbs or anything, but just sort of being free and trusting that the system is going to work. Unfortunately, the system is not quite that good yet, but, people are using it in weird ways. So we're seeing it. And so, I'm like collecting the data, and then I see it. And because, I'm a diabetes educator, I can take a look at it, and it's like, well, let's talk about this. And sometimes, we'll talk about things in advance. And they often are asking about, well, if I'm not coming in, how do I get my A1C? Because we've taught people about A1Cs and how important it is. Let's see, your A1C last time was this, and now it's that. And so what are we going to do about that? And so there's various ways now to get the glucose management indicator, or the GMI. And that shows up in the LibreView ambulatory glucose profile, or the AGP report. And a good place to get a 90-day one is in the Dexcom. And you can, so when you go in the Dexcom Clarity, you can say, give me 90 days of data. So you can get a glucose management indicator for 90 days, which is really probably our closest equivalent to an A1C. And the JAPE Center for Health Research, which is the group that we've done a lot of our studies with. They've been involved in doing studies for the T1D exchange. And so we've worked with them a lot. And Roy Beck and Rich Bergenstahl has been really sort of working on, the A1C versus GMI. And Roy Beck is at the JAPE Center, and they put this little calculator. So you just put in the mean enter the mean glucose and then calculate. And there's a little formula there that you can see about, how to go from the mean glucose to a GMI. And so there are different ways of doing it. And now we're talking with our patients about that. And I'm talking with them a lot about time in ranges and the time in target range and what percentage they have in that target range and glucose variability. And I think we're thinking that that's a more important number than the A1C right now. So I'm, also introducing technology and medications to people. So there's some patients who are saying, I don't want more insulin. I'm worried more about my weight, and they're not on an SGLT2 or GLP-1. So I'll mention that to the patients and bring it up as a possibility. Now, whether or not they can actually take that medication or, depending on what other medical condition they have going on, every day I realize that I didn't go to medical school, and then there's limitations to what I can share with them. But I know about these new drugs and how they work, but so I can introduce them. And it's like, well, is it, it's like the commercials, talk to your doctor. Is it right for you? Then I'm also talking a lot about the inhaled glucagon, Baqsimi, and, I'm linking, we used the InPen in a research trial recently. And for type 1s who are injecting, and tons of them are doing that, there's a dose calculator. So you get a lot of the same features that you have on an insulin pump. So I'm sort of mentioning that from time to time as well. Now, of course, the treatment decisions are always by Dr. Peters, and she has to look at the record and talk about them. But often, there's the pre-population of the conversation. Somebody is taking a look at Control-IQ beforehand. They're looking at the different pump options. I wrote an article about the hybrid closed loop options, talking mainly about the loop system and then the new tandem pump. And so that initial conversation happens beforehand, and the patient gets to go out and do research. And by the time they get to Dr. Peters, then she is on the verge, she can be ready to actually start the prescription and prescribing it. And fortunately, I sort of know, I worked with Dr. Peters long enough, I know how she practices and what's, her preferences are. And so I just have to be know where my limits are between being a diabetes educator and a practitioner, and knowing that I can introduce things, but she's the one that makes the decisions and gets to do the prescribing. Now, way back when my first clinical trial is with the JAPE Center that I mentioned before, and Tidepool was introduced to us to use as our platform. And so we wanted to collect all the data. We wanted to collect pump data and Dexcom data and meter data. And we were comparing Dexcom with a meter. And the Tidepool team, Howard and Brandon, got on a teleconference with us. And that time, I think it was a Google Hangout. And suddenly they shared their screen with us. And they were showing us a live view of the Tidepool platform. And a light bulb in my head went off saying, this is a telemedicine visit. And this is how, we could be doing these visits. People don't need to come in all the time. And we started holding telemedicines. We had patients in Bakersfield and, in San Francisco. So, it was always tough for them to come in. So that was our initial telemedicine crowd. But, I saw this, and then now we sort of jumped forward to, the coronavirus kicked us forward into doing this telemedicine world. And, it's going to be really interesting about, are we ever going to go back, or where are we at with it? So I'll stop now and get a chance to take some more questions that may have come in and see what you all are interested in talking about.
Sure. If you want, I can read a couple of these questions. You mind taking down that screen share for me, that we can get a full view of that awesome backdrop in your office. We got a question in from Judy, and this actually is relevant to the last slide you shared. Are you planning to continue routine telemedicine visits post-acute COVID crisis? Like, once whatever the new normal is, are you going to be trying to stick to, as much as possible, a telemedicine first approach with your patients?
I don't know how much we're going to go back. I'm not sure I think I think telemedicine is really sort of here to stay, and we're going to be doing it more.
Mhm.
And I think we're going to be in this keeping our primary care patients away from us for like the next year at least until a vaccine. So this is going to go on a while, and patients are going to, appreciate not having to drive into the office. And some people will want to come in and get their blood drawn and, have that in-person visit. But I think this is really going to be the shift towards telemedicine.
Yeah. Sort of a comment, and I can turn into a question from Dr. Saleh D. Hi, Saleh. Welcome. He's saying it's time well spent teaching patients how to upload their data at home, as they will continue to do so even when we return to normal in-person visits. And I guess my question based off of that is how often, or do you see a lot of success in getting patients to that subsequent upload? Like, generally speaking, and this is a challenge that we are trying to address at Tidepool, just with our general communications with new users, getting them to the first upload is often the most difficult process. And then once they see how easy it can be, getting them to upload a second or third time or just down the road is often a lot easier. Do you find a lot of success in teaching patients who are able to, upload at home, obviously independent of those technology, or acknowledging those technology barriers, for the ones that can upload from home? Do you find that you are successful in getting them to upload from home in advance of subsequent visits?
Well, some of them do, and some of them are doing already. And I know I talked to the patient the other day who said, she said, I always upload from home, but they always, whenever I walk in, they say, give me your pump. And so
Mhm.
they upload, in the office already. Because the last upload I see is like in the pump software. She says, I uploaded the Tidepool beforehand, and
Right.
they didn't know. They said, give me the pump. And so we've trained people to be sort of helpless and not, did you upload from home already? We don't ask that question. So we just say, give me your device. We assume that they don't know. And so, it does take some time. And whenever I'm meeting with a patient and I'm like showing patients in the data in Tidepool, I'm always, I teach them how to do uploading. And I show them the process. I have them sit there as I'm sort of pushing the buttons and say, now you can do this at home. Say, I want you to take a look at your data. And, occasionally we have people go through and they learn from what they're doing.
Mm-hmm.
As I say, what our patients do every single day, it's sort of, you're doing your best guess all the time. And by going through and reviewing your data, you can see, when you overrode the pump, did you make the really a smart move, or, did not work out that time?
Right.
And so it's like, well, take the opportunity to learn about your data, learn what you're doing, so you get to make better decisions in the future.
Yeah. Thank you for that. Question from Sue Kirkman. Hi, Sue. Thanks for asking. Thanks for sticking around. Our health system is moving to Doximity Video. It's a FaceTime-like application, and patients only need a smartphone. I guess my question to you, Mark, is you already have access to the Zoom platform. That is your technology of choice for those virtual visits. Were there other applications you considered? If there's any that you'd like to comment on, when it comes to what would it take for you to move off of Zoom? Are there any specific features that you would like to see in your telemedicine software that you don't see yet, that you would like to either have Zoom update to, or have some new thing come around that could accomplish?
There's people who have looked at all the different platforms, and our university created a system that tied in with the medical record, so that when somebody is scheduled for telemedicine, it sort of triggers the email and the tech support and all of that.
Mm-hmm.
And perhaps that will get better. So we looked at that platform as well, and then suddenly Zoom became available for us, and the other platform wasn't working, so we just switched to Zoom. And so we went with that and then stuck with it so far. And then we're using FaceTime a lot, as our phone version of doing this as well. But we're really liking the screen share feature that, that both of us have shared right now, of sharing data with the patient.
Yeah.
So you saw that screen where, James Jellyfish, I'm not sure if James wants to reveal himself.
No, I am James Jellyfish. I like to brag about that whenever I do my clinician demos. Actual patient data.
But showing the data live in the full screen view, and going it over with the patient, I think is really powerful, because it's even better than sitting with a printed report with the patient and, trying to look at something upside down and pointing at it with your finger and having the right report. It's not the same as both of you looking at the same data together and scrolling the mouse around and talking about the data. I think that works really well. And if there's other platforms that do that, there's Google Hangout, and Chris, you probably know more of these than I do, and you probably tried them all. I saw that, the work at home thing, Tidepool has gone through 15 different platforms, right?
Yep. We have put a lot of those through the ringer. That is for sure. We've actually got a couple more questions that have come in. Well, this one is from Alex. Alex, I see you're still in the chat. Thank you for attending, and thank you for your question, Alex. Mark, for you, in your opinion, we say that we as providers using telemedicine for diabetes during this crisis can help legislation to approve this format for the future. Is there some sort of opportunity to make this become the norm, become the de facto way for diabetes care?
I think, reaching out, and I go, and I've been with the American Diabetes Association to the call to Congress and walked around the halls and done advocacy for them before. And I meet with our representatives in our local office as well. So, definitely get engaged with that process. And, we'll see. It got turned on automatically, and I think we're going to get lots of feedback. And I don't even know who turned it on for us to allow us to hold the telemedicine visits. But whoever did that, reach out to them and say, yes, it's working, and continue with it. And I know that the diabetes educators who are nurse diabetes educators can't bill for telemedicine, but registered dietitians can. And there's like some quirk in the billing thing that people are trying to work out. So there's groups that are doing advocacy over that. So, take a look and see if you can find out who those groups are and who they're talking with. And that's the group to continue with and follow up on with advocacy to have, billing questions and issues, afterwards. We're down the road from here.
That's the perfect segue into this next question from Victor. Hi, Victor. Thanks for sticking around. How are you billing for the time you put in to get data if you're not part of the actual visit? Are you creating a separate visit? So this is going to be, before we get to there, again, this is going to be specific to California, to your billing department. There are a lot of caveats here, but generally speaking, how are you approaching that?
Yeah. I'm one of the worst people to talk about billing. So I'm going to have to essentially say, I don't know. Because, my job, my position is research, and I'm certified as a diabetes educator, diabetes care and education specialist now. But since I don't have a clinical designation, I came through that from having a health-related master's degree. Mm-hmm. And so I can't get a clinical designation to have a billing code. So I don't know. And it's a question, I think, do you have somebody like me? Do you have your diabetes educators collecting the data, or can our medical assistants take over this role? And so down the road, it's like, how long can this go on? And I don't know. I think it's a great question. And maybe once we sort of get the hang of it, then it can shift back over to our medical assistants to do reaching out. And once a lot of our patients know more, perhaps they can be doing it, just like our scheduler was able to take over doing the scheduling sort of once I got the system up and running. Mm-hmm. So then that's one of the other big questions and unknown, and I don't have the answer to it. And if any of you do, then let us know as well.
Awesome. All right. Last question/comment. This is from Janice. Hi, Janice. I see you're still here, and they're actually be wrapping up after this. She was adding in, commenting on the value of the screen share, saying screen share is so important to have available for diabetes consults due to the importance of data in managing diabetes, so we can view the data together as a team. Here. Yes, I like that. Yeah, I mean, I guess this is a lovely opportunity to remind everybody that Tidepool can help facilitate those telemedicine appointments. Everything you see as a clinician, whenever you log into your clinician account, in Tidepool is exactly what your patients see within Tidepool. The data presentation is identical. So whenever you are reviewing data with your patients, you can use Tidepool as a platform, as a tool to help teach your patients how to interpret their data on their own in the future.
And Christopher, before you tie up, I'm also sort of like meeting with people afterwards, and there's a number of people that I've taught to put on a Libre Personal, through Zoom, and so it's great for that. And teaching people how to change the basal rates on their Canada pump, and I'm using the T Simulator app, and so we're using video to do diabetes education that way as well with devices.
That is awesome. I love to hear how technology can help make a difference, especially in these wacky times we are dealing with right now. So as a reminder, everybody, thank you again for tuning into this week's Tidepool for Telemedicine webinar. Again, next week, we've got a couple of webinars scheduled. One is with Amy Jose from Steady Health. We'll have a link that'll be going out to all of you and to everybody else watching the archive. That'll be up on tidepool.org/webinars in the next day or so. And again, next Tuesday, Designing for Accessibility with Color with product designer Paul Forgione. He's a good dude. He speaks very passionately about this stuff. As always, tidepool.org/telemedicine is the one-stop shop to go to get acclimated with Tidepool, understand how Tidepool can help facilitate your telemedicine appointments. And when in doubt, support@tidepool.org is the email address, that you should be contacting if you have any questions about how to use Tidepool's software in the future. I'm going to escape out of this one more time, drop the screen share, and say thank you all again for attending this week's Tidepool for Telemedicine webinar. My name is Christopher Snyder from Mark Harmel on the other side of the country. Mark, give us a wave, and you'll have a great day.
Bye.